disorder scheduled for surgery, the entire perioperative course hinges on our initial assessment. This assessment is our clinical foundation. It's how we stratify risk, and that risk level dictates all subsequent management decisions, including the critical choice of whether or not to involve neurology.
So this risk stratification breaks down into 3 clear levels of seizure control: well-controlled, moderately controlled, and of course poorly controlled. It's incredibly important to get this right, because which category your patient fits into is going to fundamentally change how we approach their preoperative clearance.
Okay, let's define these terms precisely because they form the very backbone of our decision-making pathway. A well-controlled patient is our lowest risk category. We're talking about someone who's been stable on their anti-seizure medication, their ASM regimen, with 0 seizures for a good 6 to 12 months. Next, we have moderately controlled. These are patients who might have a breakthrough seizure here and there, but it's infrequent. Think less than 1 per month. And then you have the poorly controlled group. This is our highest risk category, and it includes patients with frequent seizures, more than 1 a month, anyone who's had a recent cluster of seizures, or has a history of status epilepticus.
Let's begin with the most straightforward case. This is Pathway A, which is designed for the well-controlled patient. You can think of this as our green light pathway.
For a patient in Pathway A, the management is quite direct. As the anesthesiologist, you can generally proceed with clearance, and a neurology consult isn't typically required. The guiding principle here is continuity. You'll continue all of their anti-seizure medications. The morning dose can be given with a small sip of water. It's also important to note what we don't need to do. There's no indication for routine EEG or neuroimaging. The only time you check ASM levels is if you have a specific concern, like suspected non-adherence, or if the patient is on a drug with a very narrow therapeutic index.
All right, now we'll address the more complex scenarios, pathways B and C. These pathways are for our moderately and poorly controlled patients. And as you'd expect, managing these higher-risk individuals requires a more cautious and collaborative approach. Let's look at these 2 pathways side by side to really see the difference. For Pathway B, the moderately controlled patient, you can proceed with clearance, but a neurology consult is strongly advisable. This is especially true for an elective surgery, where there's time to optimize their regimen. Now shift your focus to Pathway C. For the poorly controlled patient, a neurology consult is mandatory before you can even consider clearance. For an elective case, the surgery is postponed for optimization. The urgency of the surgery also plays a huge role. In both pathways, you're going to continue their ASMs, but for Pathway C, neurology has to be involved in the perioperative plan, and you need to be thinking about IV formulations. And look at the last point, ASM drug levels. They're recommended for Pathway B, but they become mandatory for Pathway C.
This brings us to preoperative investigations. The question of what to order isn't one size fits all. It really depends on the patient's specific pathway and their overall clinical presentation. Let's walk through the matrix for these investigations.
As we examine this table, you can see the rationale behind each test. First, ASM drug levels. These are indicated for all patients in pathways B and C. Basic metabolic panels, including electrolytes and LFTs, are prudent for all patients to screen for potential triggers, especially if they're on older ASMs. Then we have drug-specific monitoring. For example, a patient on valproate or carbamazepine needs a CBC, and for valproate specifically, we also check a coagulation panel to assess for coagulopathy. It's also critical to see that EEG and neuroimaging are not routine orders. We reserve these for very specific indications, like a significant change in seizure semiology or the appearance of a new focal deficit.
Okay, let's drill down into the specifics of anti-seizure medication management. The practical handling of these drugs in the perioperative period is absolutely crucial for maintaining seizure control and ensuring patient safety.
This table is a really practical guide. You'll see that some ASMs, like levetiracetam and valproate, are straightforward. They have IV equivalents with simple dose conversions. But then you have medications like lamotrigine and topiramate, which do not have an IV form. The critical point here is that these must not be stopped. If a patient is going to be NPO for more than 48 hours, you have to have a plan, which might involve an NG tube. Now, look at the final column on key concerns. This highlights the pharmacokinetics that directly impact our anesthetic management, things like the enzyme-inducing properties of carbamazepine and phenotone or the enzyme-inhibiting effect of valproate. This is precisely why, for valproate, we're so diligent about checking those labs we talked about earlier.
So after gathering all this information, the patient's history, their seizure control level, and their medication regimen, we come to the final clearance decision. This is where we apply a very clear set of rules to determine our next step. Do we clear the patient or do we mandate a neurology referral?
Let's start with the criteria for independent clearance. The question we need to answer is, when is a formal neurology consultation not required?
To proceed with clearance independently, it's essential that all of the following conditions are met. This isn't a mix and match list. All must be true. First, the patient must clearly fall into Pathway A, well controlled. Second, there has to be a clear, documented baseline neurological exam. Third, a concrete plan for their ASM administration, including any potential IV switch, must be in place. And finally, the planned surgery cannot be a high-risk intracranial procedure that's related to the seizure focus itself. If you can confidently say yes to all 4, independent clearance is appropriate.
On the other hand, it's just as critical to know the absolute red flags. So, when does a neurology consultation become mandatory?
Now, for mandatory referrals, the logic is reversed. If any single one of these criteria is met, you must consult neurology. This includes any patient in pathway C. It also includes anyone who has had a seizure within the last 3 months or a history of status epilepticus in the last 6. If the patient has a device like a VNS and the team isn't familiar with its management, that's a mandatory consult. Same goes for any new, unexplained neurological deficit. And of course, if the surgery is for the epilepsy itself, like a temporal lobectomy, neurology must be involved. Any one of these is a hard stop and requires a referral.
In the end, this entire clinical pathway provides a robust framework for our decision-making. However, it's a tool to support, not replace, our clinical judgment. It's important to remember that the